am Dr. Pranab Kumar Chowdhury, a senior consultant internal medicine specialist in Guwahati. I'll be speaking on ARB uses in the COVID-19 patients. To date, the 2019 novel coronavirus outbreak is being a major concern for scientific community to treat the potential medications. Following a rapid increase in the cases of COVID-19, different observational studies are undertaken to identify the possible risk factors for infection and related poor outcomes. 17% diabetes cases were reported among 52 critically ill patients with COVID, and 16.2% and 23.7% hypertension cases were identified from 1,099 patients by Guan et al. In China. Similarly, out of 140 hospitalized patients, 12% diabetes mellitus cases and about 30% hypertension cases were observed in critically ill patients with COVID-19. Hypertension was independently associated with the severity of COVID-19 on admission, and hypertension is a risk factor for aggravation of the increase in COVID-19 patients. The large percentage of patients with hypertension undertaking ACE inhibitors or ARBs was a remarkable characteristic among those patients presenting severe COVID-19 manifestations. These are classes of antihypertensive massively used as a first-line therapy due to their additional kidney and cardiologic protections that occur regardless of their use of blood pressure control. ACE2 is established as a functional receptor for the entry of SARS-CoV-2 as into the cells, and SARS-CoV-2 enters the host epithelial cell after its spike protein's receptor binding domain binds to the membrane-bound ACE2, that is angiotensin converting enzyme 2 receptor. ACE2 is the type 1 integral membrane of glycoprotein, and the highest expression of ACE2 is observed in the kidney and the endothelium, the lungs, and the heart. The probable rationale proposed for a possible relation between the use of ACE inhibitors and ARBs and progression to ARDS in COVID-19 is the increased availability of ACE2 attached to surface in the lung endothelium. An inherent effect of these two classes leading to enhanced coupling of SARS-CoV-2 to ACE2 and its consequent cell entry. Receptor binding domain of the SARS-CoV-2 has a stronger interaction with ACE2, and an increase of ACE2 expression may potentially amplify the virus capacity to entry into the cells. Distinctly, ARBs increase angiotensin II availability since this class blocks its coupling with angiotensin II receptor, leading to compensatory upregulation of ACE2 in the membrane. Cellular entry is followed by erythrocytosis and further viral replication and subsequent release. SARS-CoV-2, after entry inside the cell, causes downregulation of further ACE2 expression. ACE2 is responsible for the conversion of angiotensin II to angiotensin and to inactivate angiotensin. That downregulation of ACE2 results in the unopposed action of angiotensin II through its angiotensin I receptor. ARB angiotensin receptor blocker oppose angiotensin II action by blocking synthesis and receptor. ARB may also cause overexpression of the soluble form of ACE2, and which intercepts the binding of SARS-CoV-2 with membrane-bound ACE2, thus inhibiting the viral entry into the host cell. The new data published in JAMA Network Open show that after adjusting for multiple variables, COVID-19 patients treated with ACE inhibitors and ARBs had a significantly lower risk of death and severe adverse events, which include the need for intubation, mechanical ventilation, or admission to the ICU, and when compared with those not receiving the RAS inhibitors or BRACE Corona trial, which was presented at the ESC Congress, showed that the hospitalized patients with COVID-19 who continued on their previously prescribed ACE inhibitors and the ARBs were not at an increased risk of dying or remaining in the hospital when compared to patients who stopped the medication. The replace COVID trial, which was published, came to a similar conclusion. Abrupt discontinuation of the therapy puts them at risk of complications, rebound exacerbations of the disease, and in patients with hypertension, discontinuation, switching of the drug can lead to rebound hypertension and transient or suboptimal control with the new agent, thus predisposing the patient to intermittent high BP fluctuations, and which can augment the risk of developing CV events. Similarly, the heart failure patient's sudden discontinuation of ACE inhibitors has been shown to result in a deteriorating clinical status with a possible relative increase of mortality. In post-myocardial infarction, patients with LVD, RAS blockade provides mortality benefit. Similarly, the use of ACE inhibitors or ARBs reduces the risk of diabetic complications in patients with diabetes mellitus until more data become available. And we feel that discontinuation of ACE inhibitors, ARBs, may or may not increase susceptibility to SARS-CoV-2 infection, but sudden discontinuation of ACE inhibitors or ARB is more likely to result in decompensation of previously stable clinical state. Therefore, based on all this data, European Society of Cardiology and American College of Cardiology, American Heart Association does not recommend the discontinuation of ACE inhibitors or ARB therapy in patients with heart failure, hypertension, or myocardial infarction who are also suffering from SARS-CoV-2 infection. Moreover, ACE2, whose expression is enhanced with an ACE inhibitor or ARB therapy, has the ability to suppress inflammation and has been suggested as a potential new therapy for inflammatory lung disease, cancer, diabetes, and hypertension. Given the fact that no current evidence that proves a direct causal relationship between the use of ACE inhibitors, ARBs, and COVID-19 infectivity or mortality, and the facts that ACE inhibitors or ARBs have many benefits in CV disease. Thank you.